endocrine physiology, adrenal steroids, and congenital adrenal hyperplasias. All right, so for the congenital adrenal hyperplasias, also known as CAH, the first process that you need to understand is the table, okay? So look up the production of aldosterone, testosterone, as well as cortisol. You have to understand all those steps in between, mainly the 21-hydroxylase, the 11-beta hydroxylase, and the 17-alpha hydroxylase, okay? So those steps are very, very important, specifically with the pathologies. I'm not going to talk you through every single one of those, but you need to know overall every single one of those steps, and it will be much more helpful for the questions, okay? The first thing is that cholesterol goes to pregnenolone via cholesterol desmolase, so that's a rate-limiting step, and that occurs in the mitochondria. And the rest of the steroid synthesis occurs in the smooth ER. So that's a question that they like to ask you. Where does steroid synthesis occur? Well, it occurs at the smooth ER within the cell, okay, for the cell organelles. But it will start with cholesterol going to pregnenolone with cholesterol desmolase at the mitochondria. That's the only part that's in the mitochondria. Everything else occurs at the smooth ER, so they can try to trip you up there with cell biology. Second thing is, overall, why do these hyperplasias occur? Well, the reason behind it is because we don't have production of one thing, and it's the decrease in production of cortisol, all right? Cortisol is a very important hormone, and we'll talk about it later on. Essentially, it's actually a steroid. It's a very important steroid, and we're going to talk about it later on, actually, coming up. But what we need to know is that since we have a decrease in cortisol, we have a constant positive feedback system, okay? So cortisol can't be produced because of either a 21-hydroxylase deficiency, an 11-beta hydroxylase deficiency, or a 17-alpha hydroxylase deficiency. Okay, all of those deficiencies in the enzymes leads to an overall decrease in production of cortisol. And cortisol usually has a negative feedback loop on ACTH to tell it to stop coming and working at the adrenal glands. Well, if we can't produce cortisol, then ACTH doesn't have a negative feedback loop. So ACTH is going to continuously sense that there's decreased cortisol, and so it's going to continuously activate the rate-limiting step of cholesterol desmolase and change cholesterol into pregnenolone to start the steroid synthesis process. And this is where we're going to get the pathologies associated with it, due to the fact that there's no cortisol production, leading to an overall problem, okay, with a negative feedback loop. And then that's where we get the overactivation of either testosterone or an increase in our mineralocorticoids, leading to an increase in blood pressure, okay? So very key to understanding. Now, I'm going to point out a couple things on the chart that I want you to know that you probably wouldn't really look at and think too much about. Look at every single one of the drugs. Very important. Specifically, metyrapone, okay? That's a question that they like to ask. And then it's in the book as glyceric acid, and that's just black licorice, okay? So keep those in mind. Those are a couple questions that they like to ask about. Lower yield, but still question. And then overall understanding the pathologies of each enzyme deficiency. So starting off with 17-alpha hydroxylase, very easy. If there's a 1 at the beginning, okay, then you're going to have hypertension. All right, so if you see a 1 at the beginning of the sentence, at the beginning of the enzyme, then that means there's going to be hypertension in the child. So increased mineralocorticoids. All right. If there's a 1 at the end, like 21 hydroxylase, that means that you're going to have virilization in the female baby. Okay, and that just means that they're going to have ambiguous genitalia due to the fact that they have overproduction of testosterone. Okay, and then lastly, if there's a 1 at the beginning and at the end, like 11-beta hydroxylase, what you're going to be seeing is both an increase in mineralocorticoids, so increase in blood pressure, as well as an increase in those sex hormones, so you're going to get virilization as well in the female. Okay? So if you have 1 at the beginning, it's just hypertension, so like 17. If you have 1 at the end, like 21, it's just virilization. But if you have 1 at both, like 11, then it's going to be both hypertension and virilization. Okay, so that's a key concept to understanding this whole entire process. And they're not going to ask you a question with males. They'll only ask you a question with females for CAH. Okay, so you don't have to worry about the males. All right, and lastly, for 21-hydroxylase deficiency, I just want you to know that you're going to treat it with aldosterone. Okay, because aldosterone is going to lead to a decrease in ACTH and an overall increase in blood pressure. Okay, because with 21-hydroxylase, what's going to happen is we have that overactivating ACTH levels, right, which isn't good. So if we give the patient aldosterone, we can kill two birds with one stone. We drop the amount of ACTH levels that are floating around, so we lead to an overall decrease in adrenal hyperplasia. And we also help the patient with their blood pressure, because patients with 21-hydroxylase deficiency, there's no 1 in the beginning of the enzyme, so that means there's no hypertension. That means they're hypotensive. So we can give them aldosterone to kind of kill two birds with one stone, decrease the ACTH and increase the blood pressure. All right. So overall, that's what you have to know for the adrenal steroids and congenital adrenal hyperplasias. Memorize that table. Keep in mind everything that's important, and you should be good to go.